All right, good evening, everyone, and I hope we're having a splendid Tuesday. I hope we all had a good start to the week, and we are all welcome to this webinar for today. I'm sure people are still joining in, so we'll be starting in 1 to 2 minutes. So thank you all for joining in. My name is Dr. John Afam Osemene. I'm a senior registrar at the Department of Anesthesia and Intensive Care in the Federal Medical Center, Asaba. I am also the trainee representative of the Nigerian Society of Anesthetists, and it's my great pleasure to welcome you all to this webinar. This is the Residence Webinar Series. It is a series of educational webinars It's a series of educational webinars powered by the Nigerian Society of Anesthetists, specifically the Educational Committee of the Nigerian Society of Anesthetists, which is chaired by the President-elect, Professor Kenneth Kalu. We are grateful to the Educational Committee and to the Chairman of the Educational Committee, Professor Kenneth Kalu, and to the entire leadership of the NSA, led by Professor Al-Hassan Dati, for their support and for their enablement to ensure that we as residents keep having this residence webinar series, which is a great way for us to learn, share ideas, share knowledge, and even develop our presentation, moderation, and anesthesia skills. So without further ado, I would like to welcome everyone. If you're just joining in, we are very happy to have you. We can see some of our teachers and trainers here. Thank you so much, Chiefs, for being here. We really appreciate your presence. I'll be introducing the moderator for the day now. He's a senior registrar in the Uniosun Teaching Hospital. Dr. Paul Oyebola. Dr. Paul, you have the floor. Welcome to the webinar.
Thank you very much, sir. Good evening once again, everyone. I'm happy to welcome us to this presentation. I will be using the mic to the presenter in a few minutes, but then I have to run through the ground rules for this seminar. I hope I'm audible, sir, as I'm asked.
Yes, loud and clear. Thank you.
Thank you, sir. So please, first, I would like us to rename our devices to our names and not leaving the default setting by the Zoom to appear on the list of participants. So it's advisable that we edit the names and rename it according to our own names, so that for easy recognition and record keeping. Secondly, I would like us to all mute our devices pending the time that we ask for questions or contributions at the end of the seminar. So that will help us to have a clear flow, and communication is better if we all keep our mic muted. And also, I would like us to, if anyone asks any question along the line of presentation, please drop your questions in the chat box. We will address them at the question and answer session towards the end of the seminar. And then thereafter, if questions arises at the time of question and answer, it's advisable that we raise our hands and we are recognized, and then we ask our questions and it will be addressed. Thank you very much. Once again, our topic for today is perioperative blood conservation with focus on Jehovah Witness patients, anesthesia for Jehovah Witness patients. And our seminarian resource person is standing by, Dr. Ishola Esther Amanola, a registrar in the University Teaching Hospital, Osogbo. So I encourage us to listen on as we go on this presentation this afternoon. Thank you very much. I yield the mic to Dr. Ishola to take us to the presentation now. Dr. Ishola, please.
Good afternoon, consultants, teachers, trainers, residents, and every other person present on the platform today. I'm Dr. Ishola. I'm a resident from Uniosun Teaching Hospital, Osogbo, and I'll be taking the topic presentation today. and it's perioperative blood conservation techniques and anesthesia for Jehovah's Witness. So, Jehovah's Witness? Jehovah's Witness are a Christian denomination with millions of members across the world, and they are a sect that believe that blood is sacred and thus would not take donate blood transfusions. And the clinical challenge with them is because of that sect, they present a unique set of surgical and anesthetic challenge. However, they're usually frowned upon in the medical settings, believed as non-compliant patients. But outside of blood transfusion, they are very highly compliant and are open to alternative medical treatment when offered. Now, the core belief and the scriptural basis is stated that life is sacred and this life is intrinsically represented by the blood, and they have certain Bible verses to back this belief. So, first is Genesis 9:4, the covenant after the flood, which prohibits consumption of blood. Leviticus 17:10, which is a direct command not to partake of blood in any form, and then Acts 15:28-29, which says to abstain from blood and is reinforced through early Christian instructions. Now, to indicate this belief, they go around with an advanced medical directive that is colloquially called the known blood card, and they carry this advanced directive that refuses blood transfusion and also absolves doctors of the legal liability. It also appoints for them an healthcare proxy that will be able to make healthcare decisions for them when they are not able to. And then this advanced directive has to be discussed with the healthcare team before any surgical intervention. Now, what are the things that are contained on this blood card? The patient's details, the name, date of birth, their contact, the healthcare agent, and it also states their absolute refusal, things that they would refuse, things that they are open to, which are personal choices. And the latest update as at March 2026 is that perioperative autologous donation is now a matter of personal choice and no longer an absolute refusal. It also confers legal protection to medical staff and contains signatures of the patient's two witnesses and the date um, when it was signed. So this is an image of the advanced healthcare directive, the front and the back, and you can see from 1 to about 12 the different sections that are usually filled and should be discussed with patients before surgical intervention. So the March 2026 update, which is a critical paradigm shift, states that using a patient's own stored blood is no longer strictly prohibited. Before 2026, autologous blood storage was strictly forbidden because it was believed that once the blood circuits, that is, once the blood has left the body and the connection to the body is severed, then the blood was no longer fit for transfusion and should be spilled. But in March 2026, the organization came forth with an update saying that storing, removing, and reinfusing of self-donated blood is now a matter of personal choice. So every Jehovah's Witness patient going forward now has the option to either accept or refuse to donate their own blood ahead of surgical intervention or treatment, as well as other blood conservation techniques such as intraoperative cell salvage and acute pneumovolemic hemodilution. Now, what remains unchanged despite this new update is that they prohibit allogenic donations and transfusions. That is, they would not receive blood products from another donor. So whole blood, packed red cell, white blood cells, platelet plasmas from another donor still remains an absolute refusal. Now the acceptability and rationale. For them, they have three different categories of things that they accept personal choice, and then absolute refusal. And the first category, category A, is the absolutely prohibited component. So the products that are absolutely contraindicated, absolutely prohibited, sorry, universally refused by all Jehovah's Witnesses include allogenic whole blood, packed red cell, white blood cell, platelet, plasma. And the theological reason, like I've stated earlier, is that the soul and the life of a creature resides in this blood, and when it is removed, biblical dictates that it should be poured out on the ground, not to be stored or reused. So transfusing whole blood or its primary four components to sustain life is viewed as a direct violation of God's law regarding the sanctity of life. Category B, which requires individual discussion and specific content. These are products of personal conscience. They can accept albumin, immunoglobulin, cryoprecipitates, clotting factors, interferons. And the reason why is that the Bible does not explicitly command abstaining from minute subcomponents of the blood. As blood is broken down to increasingly small fraction, the governing body holds that this falls outside of the scriptural prohibition on all blood and its primary four components. Now, biological reason states that minor fractions, such as immunoglobulin, would normally cross the placenta barrier between mother and child, and so is also allowed and does not violate biblical law. Now, the updates, like I mentioned, includes perioperative autologous donation, acute hemovolemic hemodilution, intraoperative cell salvage, and then epidural patch. And the governing body reframed their position that storing and reinfusing one's own blood for personal medical use can be viewed as a temporary extension of one's circulatory system. And so this made all these other options now a matter of personal conscience. So while this update has come forward, it doesn't mean that every single Jehovah's Witness now is going to accept even pre-operative autologous donation, but each member now has the choice either to accept or to refuse. Now, category C is universally accepted, and these are freely accepted by all Jehovah's Witnesses, and they include crystalloids such as normal saline, Ringer's lactate, colloids such as dextran, isoplasma, glyphosate, recombinant human erythropoietin, iron, tranexamic acid, recombinant factors, factor 8. So here, there are no human blood components. They are entirely synthetic. They are plant-based, and so they have no scriptural prohibition. There are crystalloids and colloids. They will restore the circulating volume without blood-related moral concerns. And while they replace fluid, they do not replace blood. And so they are enthusiastically embraced. Now, the ethical considerations when managing a Jehovah's Witness patient, we have to respect autonomy, and autonomy means that when you have been able to assess that the patient has capacity, they understand what their choice is, they understand consequence of their choice, they are able to digest information and then communicate what their stand is. We have to respect their autonomy, even when the choice they're making would not be the choice that you will make, or you think that that choice is not in the best interest for their health. We have to respect their autonomy. So it says a competent adult has the absolute moral and legal right to dictate what happens to their own body, including refusing life-saving treatment. Beneficence and non-maleficence. This directly conflicts with our own duty because we've been sworn to do no harm and to act in the best interest of our patients. And sometimes blood transfusion can be that life-saving option left for us to take. So it directly conflicts our duty to preserve life and prevent harm. Watching a patient succumb to a highly treatable hemorrhagic causes can cause such distress to us, but over that, we have to respect autonomy. So the resolution to this dilemma and conflict is that once they have their advanced directive, which is signed, is legit, and has been communicated, you have to respect that. And that directive also absolves you of any legal liability. So if any forced transfusion after their choices has been communicated violates bodily integrity, religious freedom, and are not ethically or legally defensible. The weight of the advance directive gives them the right of refusal. So they have refused medical treatment, and then consequence of going ahead despite that would be battery and assault. Administering blood to a competent patient who has refused, constitutes medical battery and a gross violation of human rights, exposes the physician to severe legal action, and can result in loss of license for such a doctor. Like I mentioned earlier, the directive already protects us from liability, and so um, we should make sure that we see the advanced directive. We involve hospital legal team where appropriate and avoid coercion. So discussions should be held privately. When consulting with this patient, it should be held privately with the patient to ensure that their refusal is genuine and not as a result of pressure from family members or hospitalizing committees. We want to make sure that their decision is genuine and personal and is from what their own personal belief. Now, when the patient in question is a pediatric patient, that presents a separate dilemma, and the legal standard is that the child is is a cost is a cost is that for a child the state is the parent. So the government has a compelling interest in protecting the life of the children, and so while parents have the right to practice the religion, it's believed that the child hasn't made that choice for themselves yet, and so is not held to the same beliefs as the parent. So they cannot legally martyr their child by refusing life-saving treatment. Emergency protocol requires that we involve the um, hospital legal team who can request a court order, but um, we would issue in upper acute emergency. You can go ahead to transfuse, and you'll be legally protected because state is the parent, and once a court order is underway, you can go ahead with transfusion. Now, adolescents who are patients between the ages of 14 and 17 have the right to accept blood transfusion. If the patient accepts, you can go ahead to transfuse, but if they refuse, the state as their parent overrules such a decision. So for older minors, their personal belief and accents should be heavily weighed and carefully documented. However, the legal mandate to preserve life generally will override their refusal until they have reached legal adulthood. So they're at the age where they're able to they understand, have bodily autonomy, they know what consequences of decisions. And so if that such a patient indicates that they would like to have transfusion, despite that their parents are Jehovah's Witness and believe against transfusion, you can go ahead to transfuse. But if they are also insistent on refusing transfusion, then they are legally overruled because they are yet to attain legal adulthood. Now, for the major principle of managing um, Jehovah's Witness patients coming for surgery pretty much hinges on perioperative blood conservation techniques. And this starts preoperatively, will continue intraoperatively, and continues up until the postoperative period. Now, for preoperative techniques. We have to, first of all, I've seen this patient at least a month to the scheduled surgery. And what we want to do in that period is first optimize the patient, and this would include finding out what we are diagnosing causes and mitigating bleeding risk in this period. We want to identify root cause. We want to be sure that they are not anemic. So we are going to be identifying likely root causes. So treating anemia, nutritional deficiency, whether chronic disease, whether hemolysis, bone marrow suppression. You want to find out if there's any underlying um, um, diagnosis that could predispose them to anemia. You want to treat endemic infections, so malaria, fever, parasitic infestations, things that would predispose them more to anemia. You want to address active bleeding sites, so you investigate and manage chronic bleeding sources. So GI ulcers, malignancies, severe menorrhagia. You must be able to control such bleeding causes before you begin optimization and planning for surgery. You also have to do a medication review. You want to ensure that these patients are not on anticoagulants, and you want to seize them appropriately. So you want to strictly adhere to the perioperative guidelines for stopping antiplatelets. If required, you breach your anticoagulants, and all this with the aim to minimize surgical risk. For Jehovah's Witness, their target hemoglobin is 13 grams per DL. And so once the patient has this, you can go ahead to proceed for surgery. But if it's lesser than that, you have to investigate and optimize. And we have several methods available to us to optimize such patients. And so if the ferritin is lower than 100 nanogram per mil, you can administer IV iron. If the vitamin B12 or folate is low, then you want to administer B12 and supplement folate. If major bleed is anticipated and then the hemoglobin is lesser than 10, you might want to consider co-administration of iron and recombinant human erythropoietin for rapid erythropoiesis. Now, so you make a choice of which is appropriate. We have to understand the pharmacology. And so for IV iron, they replenish iron stores for hemostasis synthesis, and the dosage is about 500 milligrams to 1 gram IV single dose, and they cause reticulocytosis in 3 to 7 days with peak in hemoglobin at 2 to 4 weeks. Recombinant erythropoietin stimulates the bone marrow to start to release erythroid progenitors, that is cells that would eventually become red blood cells, and 40,000 international units of fluid once weekly for 3 to 4 weeks prior to surgery is the usual dose. And onset is also of reticulocytosis is 3 to 4 days with a hemoglobin peak at 7 to 14 days. The mechanism for folic acid is an essential coenzyme for DNA synthesis and red blood cell maturation, and the dose is 1 to 5 milligram per oral daily. If indicated, if folate deficient, the reticulocytosis is seen in 2 to 3 days. For vitamin B12, it's also an important coenzyme that also helps in red blood cell maturation, and the dosage is 1,000 microgram intramuscularly three times in a week for 2 weeks, and reticulocytosis is seen in 3 to 5 days. Now, after the patient has been well optimized, then they can undergo pre-operative autologous donation, and when they consent to it, is done when we anticipate loss of about greater than 10 to 20% of the total blood volume, or greater than 1,000 ml, that is 1 liter of blood, is anticipated as intraoperative blood loss. The hemoglobin is greater than 11 gram per dl. And how it's done is that the patient donates 1 unit of blood, that's 500 ml of blood weekly for 4 weeks, with at least 72 hours before, with the last transfusion donation happening 72 hours before scheduled surgery. When the bloods are then stored in blood bags and banks, labeled with the patient's name, hospital number, and labeled for autologous use only, so that intraoperatively, when it's needed, such blood is then transfused back into the patient. Other intraoperative strategies include meticulous hemostasis, minimally invasive techniques. You can also make use of controlled hypotensive anesthesia to reduce the amount of intraoperative blood loss. Strict normothermia is indicated because hypothermia can lead to coagulopathy. Acute normovolemic hemodilution can also be done, and this is when blood is taken from the patient just before surgery. 1 to 2 units is taken from the patient just before surgery and is then replaced with colloid in 1 ml to 1 ml of colloid for 1 ml of blood that was donated. And if it's replaced by crystalloid, it's replaced with 3 ml of crystalloid for every 1 ml of blood donated. So this would reduce the red cell mass that is lost intraoperatively, and when indicated, the units that were initially donated is then reinfused back to the patient. Intraoperative cell salvage is another intraoperative blood conservation technique, and what this involves is that the blood that is lost in the surgical field during surgery is gathered and then processed through the live cell-saving machine, where it is washed, agitated, washed, filtered, and then reinfused. The washed red cells are then reinfused back to the patient. There are certain situations where this will be contraindicated. When the blood is contaminated with bowel content, with infectious materials, purulent materials, and malignancy. When the blood has been contaminated with procoagulants, such as Surgeon cells, so that we don't infuse that into the system and then cause systemic coagulation. Another test strategy is the thromboelastogram coagulation monitoring. And what this does is, rather than just transfusing whole blood when patient is bleeding, the thromboelastogram tells us at what point of the coagulation cascade there is deficiency, and only what is deficient is then transfused. We can also make use of antifibrinolytics such as tranexamic acid to prevent further blood loss. Now, early planning, clear communication, and multidisciplinary approach is important for the optimal to get the best results for these patients. And like I mentioned, our strategies don't just end intraoperatively, they continue even in the post-operative period. And these strategies would include restricting blood sampling. These are not the patients that we want to sample frequently. And even when it is indicated, we should use pediatric collection tubes. We want to use automated closed arterial sampling systems where little volume is needed and we can get a lot more value from such systems compared to 5 mils for every single value required. You also want to place them on supplemental oxygen to increase oxygen delivery and deep sedation when required to reduce the oxygen consumption and their metabolic rate. Now, aggressive treatment of fever and shivering is also indicated in them. Like I mentioned, you want to reduce the oxygen consumption, so you have to abolish shivering. And then permissive anemia in them is allowed if they are still hemodynamically stable. So while we have our standard protocols of maybe 27 or 30, where we want to transfuse even when patient is hemodynamically stable. In this particular set of patients, even when their hematocrit or packed cell volume is lesser than that, but they are asymptomatic, you allow without intervening. Um, Intraoperatively, some other things that could be done, minimally invasive surgeries, over open surgeries, and then controlled hypotensive technique. I think I'll discuss most of these other strategies. So permissive anemia, the core principle is that set lower hemoglobin thresholds than traditional transfusion triggers. And for the restrictive is about 7 to 8 grams per gel. However, for Jehovah's Witness, we can go as low as 5 to 7 grams per deciliter. And so post-operative blood conservation is a direct extension of the intraoperative strategy, as every millimeter saved matters. Here are my references and bibliography, and thank you for listening. So I'll be taking questions now.
Thank you very much, Dr. Ishola, for the presentation. We will be taking questions now. So far, I can't see any question in the chat box yet, and I don't see any hands raised to ask question. So the floor is open for questions and contributions. I can see a number of our revered teachers on the platform. Apologies if I do not mention your name, if I do not recognize everyone, but I can see our highly respected teacher, Professor Nwaso Ogboli, sorry, please. And also, I can see Professor Alasan Deti Mohammed. We appreciate your presence, sirs and mass. And other respected teachers here present, we do not take your presence for granted. We appreciate you, sirs and mass. We're still taking questions. So, I hope I'm still audible.
Yes, Chief.
All right. Okay, we have one question in the chat box. It says, thank you very much for the presentation. Kindly stage a scenario for the private discussion as stated during the presentation, or elaborate further on counseling with respect to blood loss. Okay. Our presenter.
All right, thank you for... Okay.
Stage a scenario for the private discussion as stated during the presentation, or elaborate further on counseling with respect to blood loss.
Thank you for the question. Usually this discussion would happen at the anesthesia clinic, and like I mentioned, is a multidisciplinary approach. So it would not be happening in isolation. It will be happening with the patient, the surgeon, the anesthetist, and hospital legal team or liaison committee present. And so having been scheduled for a particular surgery, the surgeon will be able to communicate that for this surgery, anticipated blood loss is this much. Usually would require transfusion. When the anesthetic comes and the anesthetist is doing a full preoperative assessment, finding out previous medical histories, comorbidities, airway assessment, previous exposures to anesthesia, a full preoperative assessment with focus on the blood conservation techniques in mind. And so from there on, you want to have that conversation with them with the advanced directive. What exactly do they not want? Would they not take that? Do they absolutely refuse? What are they open to taking? And of all these methods that we have available, which one would they agree to? And so from then on, having reached a consensus with all the parties that will be managing the patient, we then begin, to optimize and go down um, our um, our management plan for such a patient. I don't know if any senior person wants to add a bit more to that answer. SAS and MAS.
All right, thank you very much. I believe our teachers will comment or add to that. But let me, if I may, ask that we take this further. Maybe I should or somebody should simulate as the patient, a Jehovah Witness patient going for, say, a myomectomy. While you, Dr. Shola, you are the anesthetist and you come to review. Maybe we can play a 1-2 minute kind of scenario that this question is asking. So let me be your patient and you ask me relevant questions. Shall we?
Okay, Chief.
Dr. Shola, can you hear me? Am I audible, please?
Hello?
Can you hear me?
I can hear you now.
All right. I said this. I appreciated you for answering the question, and that the scenario that was asked. Maybe I should simulate a Jehovah Witness, say a 39-year-old woman coming for myomectomy, and a Jehovah Witness that will want to ascertain what is permissible or what is not from them. Maybe I should simulate a patient and you be the anesthetist in 1-2 minutes. Because these are likely questions in our exams at different levels.
Okay, Chief. All
All
right.
right.
Good evening. I'm Dr. Ishola. I'll be an anesthetist for this surgery. I'd
Good
like
evening,
to
ma'am.
ask you
Thank
a
you.
couple of questions and do some quick examination, and then we'll be talking we'll be discussing the plan for your anesthesia. Is that okay?
That's okay, ma'am. Thank you.
All right. What exactly what exactly brought you to the hospital, ma'am?
I've been bleeding for about 5 months now, and my doctor said I would need a surgery to remove fibroids.
Oh, yeah, sorry to hear that. The bleeding, when 5 months ago, what, how many pads were you using before, and how many are you using now? Has they increased in the number of days compared to before?
I was using 1 to 2 per day. I use 1 to 2 per day usually, but now it might be up to 5 or 6. And sometimes I feel dizzy and I just feel weak during my period.
Okay. Okay. Sorry to hear that. Any episodes of fainting? Have you lost consciousness at any point? Hello, ma.
No, ma.
Okay.
No, ma.
Has there been any increase? Have you needed to use the toilet more frequently to urinate?
No, ma.
Have you had to? Have you How often do you use the toilet now compared to before? Do you move your bowel as regularly?
Yes, I go to toilet as normally as I used to before.
All right. So, have you had any surgeries done before?
No, ma.
No, you've not had any exposure to anesthesia. You've not been put to sleep. You've not had any numbing injections for any reasons whatsoever.
No, ma.
You, all right. Yeah. Are you managing any medical conditions? Have you been told you're hypertensive, diabetic, asthmatic? Are you on any routine medications, man?
No, ma.
All right. Do you have any drugs that you react to or any foods that you react to?
No, ma.
Do you drink alcohol or smoke cigarettes, man?
No, I don't.
All right, man. So I'll just be taking quick examination. I would like to take your pulse rate, your blood pressure, and then I would like to do some baseline investigations for you. And I'll be interested in your complete blood work, your electrolyte urea and creatinine. Is is that okay? Do you have any of such results with you, Mouse, Ma?
I have them, but I'll put them in my folder.
Okay. Um. Can I know the values, Ma?
Hello.
Yes, sir.
Thank you very much. I was hoping you will cancel on the blood conservative technique that you are likely to use, mentioning the fact that bearing in mind that I'm a Jehovah Witness and the likes.
Okay.
You understand what
Having
I'm
gone
saying?
through your
Let's
yeah.
assume
Okay.
you've done
Yes.
every
Having
other thing right, but you want to cancel this woman on the likely blood loss and what you can do in the alternative if she refuses blood. I'm making her know the
no.
implication of not transfusing, even up to the level of likely mortality. I think that is what the question meant by staging a scenario for
Okay.
somebody that is Jehovah Witness and has a surgery that is likely going to be losing a lot of blood.
Okay, Chief. Having done this
Yeah,
quick
I think,
assessment,
sorry to cut you
do
in,
I
please.
got
I think
okay?
I have another question in the chat box. The
Okay.
question says, what is the recent development on Jehovah Witnesses and autologous blood transfusion? Well, I believe that was mentioned in the slide, but you can just go over it again for the sake of emphasis and to answer this question.
Okay. The March 2026 update stated that preoperative autologous donation was now a matter of personal choice. That is, it was no longer an absolute refusal and is up to each member to decide whether or not it was an option that they want to explore when it comes to surgical intervention.
All right. So thank you very much. I think I don't think we have any other question in the chat box, and I don't see any answers either. So I will yield the mic to the NSA training rep, Dr. John Afam, to round us up and appreciate our teachers and bring the presentation to a close. Thank you, sir. Dr. John, sir, you have the floor. Oh, someone is raising their hand. Dr. Azuka, if I'm correct. Apologies if I didn't catch that earlier. Before Dr. John Afam comes on the floor, then Dr. Odukuye Rukewe. I'm sorry if I'm not pronouncing your name correctly. So, Dr. Rukewe, please go on. Ask your question, sir, or your contribution.
Hello, good evening. Can you hear me?
Yes,
We can
sir,
hear
you're
you, sir.
audible, sir.
Hello?
We can hear you, sir.
All right, sorry, ma'am. I just want to make a little question. Yeah. Before I continue, let me recognize our president, Professor Dati. I greet you, sir, and my honorable teacher, Professor Unwanso. Now, I want to commend Ishola for her presentation, but I have a few observations or a few clarifications you should make. Of course, I blocked out a bit due to network, so I couldn't hear if you talked about the gimmick child. In other words, consent versus assent. Who can actually make these wishes? Can any child on over 14 years decide to actually give the power, as in accept the power of attorney? And as a doctor, will you accept that? Then another thing, when do you respect the consent of a child under the age of 14? I mean, a child. Then, as a doctor, do you accept a consent from somebody who doesn't have capacity, probably doesn't know how to reason? They just come in and say he's a Jehovah's Witness. Do you withhold treatment from that person? Then, can a patient change their minds? As a doctor, handling a patient who decided to change his mind in the middle of surgery, are you supposed to respect that? Are you supposed to accept that? Then something she said on the cell salvage, I want to just add, Nigeria here, we do not really use the cell salvage machine or for blood conservation, or to the best of my ability or knowledge, where I've practiced. But in the Senna claims, you have a real cell salvage machine, as she described. It washes the cell and reinfuses. So there used to be some contraindications with that cell machine in the past. But now you no longer contraindicate its use in malignancy. You use it for as far as possible. And when you get a little bit close to the malignant cells, you discontinue it. So it is no longer that contraindicated in malignancy. The same with pregnancy. You can use it for obstetric cases and then retransfuse back these bloods. So I just thought I should let you know as well. I'm sure some of us haven't seen the TEG, recruiting machine. It's a real-time thing where you have to see what contents of blood. Of course, you take a sample of the blood and send to the lab, but you see it in real time. What aspect of the blood needs to be transfused? So I just said I should bring this up so she can as well clarify the other questions: consent versus assent, the gimmick child, and can the child actually give consent? And do you refuse a patient? Do you actually allow a patient change his mind on the table? Thank you.
All right, thank you, Chief. Just to also add to the intraoperative cell salvage, and the course of presentation, I forgot to mention the Nigerian doctor who invented the emergency auto transfusion sets for resource poor countries like ours, Dr. Otu Obaje, who invented that in the 1980s. And so while the cell salvage, which is more complex and expensive, is what's used in other climes, the EAT set was invented for low resource countries like ours. So in the course of my presentation, I did talk about the pediatric dilemma, and I said that for pediatric patients, the state is the parent. And so while the parent holds the religious belief, it's believed that the children don't yet have capacity to make such decisions for themselves. And so a court order can be gotten to go ahead and transfuse such patients, and where it will be legally covered in such situations. However, for the GILIC patient, which is adolescent patient between the ages of 14 to 17, who capacity, have bodily autonomy, can understand consequence for decisions, the school of thought is that they can they can accept that they want blood transfusion, which is against their parents' belief, and to go ahead with that. However, they do not have capacity to deny blood transfusion until they have attained legal adulthood. So while they are 14 to 17, if they say they want to be transfused, even though their parents are Jehovah's Witness, we can go ahead to transfuse them. However, if they say otherwise, that they agree with their parents and don't want to be transfused, we cannot act on such until they've attained legal adulthood, and we should go ahead with court orders and go ahead to transfuse. Now, I wouldn't take consent from a patient without capacity. And in the course of presentation, I talked about how to assess capacity. Assessing capacity means that the patient can understand what you're saying. They're able to run the thought process, understand it, understand consequences too of them not agreeing with your recommendation, and they are able to communicate to you what their decision is. So a patient who does not have capacity is not able to give consent, and so would be treated with beneficence, where the doctor acts in the best interest of the patient. The last scenario painted was if having refused blood transfusion initially, with the advanced directive in place, if they can change their mind mid-surgery. I don't have a straightforward answer to this, but I would err on the side of caution and not transfuse, because there's an existing legal document that contradicts this new wish. Only if paperwork can then be worked on mid-surgery to approve, to show that they are the ones that gave consent and filed appropriately before going ahead to transfuse blood. I don't know if I think I attempted all the scenarios and questions asked.
Okay, sorry, let me just come briefly. Please. You
Sorry, sir, you're breaking up. Sorry, I can't hear him clearly. Am I the only one with that
No,
problem?
his line is breaking. His line is breaking.
We can't hear him, please.
to change his mind mid-surgery. So if you are looking for a paperwork, that patient will accept it.
Sorry, I can't hear anything.
Can you hear me now? Can you hear me now?
We can
Yes.
hear you
Okay,
now.
we can hear you now,
You're
sir.
audible
Initially,
now.
his line was breaking. We could hardly hear
Okay,
it.
let me quickly tell you that if a patient decides to give consent for accepting blood, despite having signed an advance directive, a patient who is competent and awake, probably under spinal, the patient can change his mind midway into surgery. And as a doctor, you should oblige to that. There's no time to do paperwork for a patient who is dying. So you should oblige the patient and document and communicate your documentation. So that's the answer to that. You can give.
All right.
Okay. All right.
Hello.
Hello, sir.
Thank you for your presentation. Good day, my teachers. I just want to add before I will now ask my question. Under the intraoperative anesthetic management to salvage blood, you measure the ANH, that is acute normal volumic hemodilution. So I also want to ask if to add that apart from that, there can also be acute hypervolemic hemodilution. I don't know whether the word is correct, but in a way that if you know that somebody is having a PCV of or hemoglobin of let's say PCV of 30, and you don't want the actual patient blood to be lost during the surgery, you can give fluid, maybe 1 liter or 1.5 liter, increasing the volume, though you dilute the blood content, so that if actually the patient will end up losing maybe 1 liter, you know that part of the 1 liter is IV fluid that is lost. So in that form, I think is also part of intraoperative blood conservation. Then I will ask my question. I've been thinking, if an unconscious patient with an identifiable tag as a Jehovah Witness is rushed into your facility, maybe by passersby or friends, and the patient is bleeding, and the patient needs urgent emergency surgery to stop the bleeding, and the patient will require maybe up to 4 pints of blood. In that case, knowing that the patient is unconscious as the Jehovah Witness patient, how do we do it? Do we just go ahead and transfuse to save the patient's life? What if patient comes up conscious and decide to sue that he was not to be transfused before the surgery? Or do we need to seek legal intervention before we transfuse? How quick are we going to get? Is it power of attorney within the moment of carrying out the emergency surgery? That is where I need clarification. Thank you for the presentation.
Thank you for your question, Chief. The unconscious patient with an advanced directive with a tag that indicates that, well, how to go about it? The advanced directive also has healthcare proxies that should make decision for them when they are unable to, when they are incapacitated. So I believe that the next line of action would be to reach out to the healthcare proxy to make a decision for them. However, if you are unable to reach a proxy, I believe that the advanced directive is what holds, as the patient is not conscious, to communicate a different decision to you. So unfortunately, while it would be morally distressing, ethically distressing to just watch a patient die to a treatable cause, in that scenario, I believe that the transfusion is not to be given.
Please permit me to contribute to that, your answer. Can I say something?
Yes,
If I
Chief.
understood his question very well, if a Jehovah Witness comes to the emergency without an advance directive, and
So
somebody
you said the
just
patient has a tag.
no,
That's what I
if
heard.
no, if the patient has a tag, then you follow the advance directive. But the teaching says that if a patient whom you do not know what the advance directive is, or you do not have any advance directive, please do not withhold any treatment. Okay, treat to the letter. Now, if there is a family member who is not a proxy, just as you said, or there are family members around without an advance directive and keep saying, this patient is a Jehovah's Witness, please don't transfuse. Please, nobody can take a decision for a person who is unconscious without any legal binding advance directive. So you must treat the patient optimally as if he's not a Jehovah's Witness. I think you see it in some of the, I think it's in some of the books. You will see it there. Do not deny a patient treatment without any advance directive, and nobody can take decision for that person if they don't premeditated advance directive at hand.
Oh, thank you very much. Thank you. Well understood.
Thank you very much, sirs. I hope we've had some clarity on the questions that were raised. I can see one or two questions in the chat box. Who invented the EAT set, and what is the proper method for autologous blood donation? Well, I believe I believe the presenter have done justice to some of these part of the questions. Our time is past spent, and we wouldn't like to eat into the other activities of the day that individuals have for today. I believe Dr. John Afam is back on the chat now.
Paul, I was there. I never left. Welcome. Thank you so much. Can you hear me?
Yes, Chief, you're audible.
Oh, lovely. Okay, thank you so much. And yes, like you
Doctor,
said, our time is actually
all right, thank you, sir.
and I guess whatever outstanding questions that have not been treated, we'll continue the discussion on our residents group. I think it has been a very enlightening session, especially regarding the new updates. And we are very grateful to our teachers and trainers, especially our chief, Dr. Dukoye, who has done a lot of clarity and explanation for us. Thank you so much, sir, for your presence here. As usual, like I mentioned, okay, we have a hand up, Dr. Nana. Chief, you want to say something?
Yeah, yes, Dr. Afam, good evening.
Oh, sorry. Good evening, sir. Welcome, sir. Thank you, sir, for being here.
Yes, thank you. Thank you for recognizing me. And good evening to our teachers, our seniors who are here present. I'm Dr. Nana, the PRO of the NSA. Just to give a few announcements. First is to appreciate the presenters and the coordinator and Dr. Afam for doing a wonderful job coordinating this residents webinar. The second thing is to encourage residents to kindly pay they are encouraged to pay the NSA annual dues. It's on the platform. The account number and the fees is also on the platform. We also want to notify you people that our conference, NSA annual conference for GGM, is coming up sometime in November. Notices are already going up, and we should start planning to attend, as well as other conferences being planned by other societies that are affiliated to the NSA. Society for Specialists in Airway Management Conference is coming up by the end of this June. That of the ICCSN, that is ICU, Critical Care Society of Nigeria, is coming up sometime in July. That is of the Obstetric Association. Obstetric Anaesthetists of Nigeria is also coming up, and the Pediatric Anaesthetists Association of Nigeria is also coming up. Let's all plan to attend and be part of these conferences. Thank you. And God bless everyone. Thank you.
Thank you so much, Chief. Much appreciated. And we'll continue sharing the information and the updates on our group to encourage people to join in and key in. Thank you so much, sir, for the announcements. Okay, so like Chief has said, we know that this session is powered by the NSA, so we need to continue doing all we need to do to support the NSA by registering, paying our dues, and attending our annual conference, which is in Kanu at the end of the year. So without further ado, thank you so much, everyone, for joining in. We are grateful to the NSA for the platform, for the support. And our president is here, Prof. Dati. I don't know if you have a few words, sir. I don't know if he's online. But
around. Thank you.
Thank you so much, sir. Welcome, sir. Always a pleasure to have you on here, sir.
Yeah, thank you. And I don't know, but there is Professor Nwaso. I don't know. She's always around, unless if she's sick.
Yeah,
but,
she's here. Yeah, but I don't think she said
Mm-hmm.
anything today. Welcome, ma.
Okay, so okay. So maybe let me, before I forget, before my internet start acting up again, I thank the presenters, the presenter and the moderator. Wonderful job. And I'm always happy to see this program going on. We know we are benefiting and we are getting better and better. Now, two things came to my mind. One, in general terms, we will find a way of packaging all these presentations. You'll be surprised at the work you have produced. And it's good when you package it and you are accessing it in volumes, and you can have a quick revision for your practice and also for exams. So we will initiate something. Dr. Afam, I will discuss with you in detail what I mean. And then yes, possibly when we have that, now that our website, hopefully in the coming weeks, will be back. And when it comes back, it will stay forever. So we will fine tune everything. The second specific thing about this presentation is that we are, for the background, very senior colleagues. We are looking at our standard guidelines for safe practice of anesthesia in Nigeria. And it's not an easy job, but it's been done. So there are special groups of patients, and this Jehovah's Witness is one of them. I enjoyed the discussion, but I think I know they are very well organized group. I will try to trace them in Kano again because they have a group. They are very friendly people. They will give you all the resources and all these things. So we need to know their stand now so that we can factor in our standard guidelines this special group. And if we have that, we have information from them, we'll be able to now factor it into our standard guidelines so that we'll all be guided. So we'll be avoiding all these medical legal issues. So those are the things I want to say. Thank you very much. Maybe Professor Nwaso, if she's around, allow her to just say one or two words. Thank you.
Thank you so much, sir. Thank you. Always a pleasure to hear from you, sir. Thank you, sir. Prof. Masoma, I don't know if you're online, ma. I can see you. Thank you so much for always joining in and publicizing our webinars, ma.
Yeah, well done. Yeah, I'm online. I've been listening to the discussion, very engaging. But I was not impressed about the when you were the speaker was trying to simulate, talking to a patient, Jehovah's Witness patient, and I think the moderator was trying to direct the discussion, but I don't know, they didn't eventually get to do that. So I would like people to go back. Those are things that you could be asked, like they could ask you form of history taking or consent, or informing a patient about a procedure or something like that. It usually is important that you get it right. That's what I just wanted to point out. So it's been very good. Well done. Thank you for all that you are doing.
Thank you so much, Prof. Ma. Always a pleasure to have you, and thank you for your comments. We would ensure that we continue discussions and set up a platform where we can also have some of these discussions, even on a smaller scale. Thank you so much, Ma. And I think with that comment from our big madam, our big prof, I think we have come to the end of this particular webinar session. So thank you all for attending. We are very happy with the turnout, and I'm certain that the discussions were quite engaging and we all gained something. The recording will be out and will be published on the NSA YouTube channel. And when it is, it will also be communicated among the various groups so that we can have access to it. In the subsequent residence webinar will be publicized as usual, and we look forward to everyone here and even more persons joining in to make these discussions more engaging, more interactive, and more educational. As usual, we are very, very grateful to the NSA, to our teachers, to our trainers, to everyone who makes this a success and who takes their time out to join in and impart their knowledge on us. We are very grateful, and we look to continuing the anesthesia practice to the highest quality standards as established. So thank you so much. And with this, we have come to a close of this webinar session. Have a good evening, everyone, and see you next time. Take care.